Hello everyone, a very good afternoon to all of you. So today I'm going to talk about one outdated terminology which has been removed way back in 2017, but we still use it. Okay, it is nothing but chronic and aggressive periodontitis. Okay, so chronic and aggressive periodontitis terms have been removed way back in 2017. Okay, but we still use it. So the reason for eliminating these terminologies, what they give is they framed certain evidence-based results, so that these terminologies should be removed or it does not have any kind of significant distinct features. Okay, in such a way, the first thing they talk about is there is more overlapping of clinical features. Okay, there is lots and lots of overlap of clinical features between these chronic and aggressive periodontitis. What does that mean? The first one, age. So most of the times they say that aggressive periodontitis comes in early stages, like say for example less than 30 years, or localized aggressive comes in prepubertal or circumpubertal. And bone loss. Okay, see, nowadays evidences show that age, irrespective of the age, say for example, it doesn't mean that only if a patient comes with less than 30 years it's going to be aggressive, or more than 40 years it's going to be chronic. No, they have eliminated that, and it is not purely based on age. Okay, this factor is eliminated. So bone loss, if you see, there are patients with vertical bone loss having chronic periodontitis, and there are patients with horizontal bone loss having aggressive periodontitis. So looking at this, they eliminated the concept of only aggressive periodontitis patients will have vertical bone loss and chronic periodontitis patients will have horizontal bone loss. So this factor is again eliminated. And then the clinical attachment loss or level. So clinical attachment level, again, they say that sometimes a chronic periodontitis patient will also have a rapid amount of bone loss, will also have deeper pockets. And not only the aggressive periodontitis patients will have deeper pockets and rapid progression. Okay, so the first criteria they ruled out is the common overlapping features of the chronic and aggressive periodontitis. Second one, what they tell is the microbiological profile. So if you remember, the most common bacteria which is associated with aggressive periodontitis is going to be Aggregatibacter actinomycetum comitans, isn't it? Aggregatibacter actinomycetum comitans. Okay, and the most common bacteria associated with chronic periodontitis, it varies. P. gingivalis A. So what happens is, over a period of time, they found out that the same pathogens are associated with both the types. They just vary in quantity, and the virulence factors of the microorganisms vary. But both organisms are present in both the diseases. Okay, so the microbiological profile again does not show significant distinctive features, right? Okay, now the third thing what they rule out is genetic aggregation. Okay, we have heard that aggressive periodontitis patients, they are more prone for the familial aggregation, but over a period of time they found out that it is not of significant feature, and they ruled out genetic aggregation or familial aggregation of the inheritance of aggressive periodontitis. Okay, next is the host response. Host response is our body response to it. So in aggressive periodontitis patients, we have heard that there is going to be increased hyperactive immune responses, like increased neutrophil chemotaxis, increased pro-inflammatory cytokine production. Okay, but over a period of time they found out that the host response totally depends upon certain risk modifiers like smoking, diabetes, and socioeconomic status, rather than blindly telling that aggressive periodontitis patients will have increased or aggravated host response and chronic periodontitis patients will have a normal host response. So they are shifting towards more evidence-based response of the host, like they are finding out whether the patient is having smoking or diabetes, or depending upon the bone loss per age and other certain factors like microbial deposits. Fine. Okay, now chronic and aggressive, if you ask me, maybe over a period of time your questions will not, you will not get any questions stating that what is or how much extent, whatever it may be relating to chronic and aggressive. Okay, so what is the terminologies which you will get over a period of time is a new classification system called staging and grading. Okay, so staging and grading, these two terminologies you are going to see for the rest of your MCQ examinations, because these are all the newly updated classification of periodontal diseases which you are going to see, which are updated way back in 2017. Okay, what they grouped these chronic and aggressive periodontitis, they group both these as a common terminology as periodontitis. Okay, so you're not going to diagnose a patient telling that he or she is having generalized aggressive periodontitis or chronic generalized periodontitis. No, those terminologies are removed. So what you are going to do now is you are going to stage the patient and grade the patient. Okay, so now what is this staging and grading? Very, very important. Okay, so they have given 4 stages. Okay, so 4 stages of periodontitis has been classified based on 2 things. Okay, based on the severity and based on the complexity. Okay, so based on the severity and complexity, they have classified periodontitis as 4 stages. Okay, so the first severity what we are going to talk about is the clinical attachment loss. So the clinical attachment loss, if you see, I have posted a detailed video of what is PPD and CAL. You can watch into it. I'm not going to talk anything about what is CAL and how to measure it. Okay, I'm just going to tell the values to now. Okay, so the CAL for stage 1 periodontitis will be 1 to 2 mm. So the CAL for stage 2 will be 3 to 4 mm. And for stage 3 and stage 4, it's going to be more than 5 mm. Okay, so next severity what they used is bone loss. So if you look at bone loss for a stage 1 periodontitis patient, it should be less than 15%. I'll tell you how to measure a bone loss. Okay, and for stage 2 it will be 15 to 33%, and for stage 3 and stage 4 it is more than 33% or more than middle third. Okay, so the radiographic bone loss. So first one is CAL, next one is radiographic bone loss. How to measure a radiographic bone loss? It's very, very simple. Okay, so you take a look at this IOPA. I'm just zooming it out for you. Okay, is this patient having bone loss? Obviously yes. Okay, so what I'm going to do is I'm going to take the reference point, say for example CEJ. So I'm going to identify CEJ. You cannot detect CEJ radiographically, so I'm going to just assume it. Okay, so let us assume the CEJ is somewhere here. Okay, so what I'm going to do is I'm going to measure the distance from the CEJ to the alveolar crest. I'm going to measure the distance from the CEJ to the alveolar crest, and then what I'm going to do is I'm going to measure the entire root length as well from the CEJ. Okay, so I have measured 2 values now. I measured the distance from the CEJ to the crest of the alveolar bone, and also I have measured the distance from the CEJ to the root apex. Okay, say for example, this is 4 mm and this is 12 mm. Okay, so the distance from the CEJ, okay, the distance from the CEJ to the alveolar crest is equal to 4 mm, and the total root length will be 12 mm. So in this patient, how I'm going to calculate the radiographic bone losses? I'm going to divide the distance from the CEJ to the alveolar crest with the total root length, and I'm going to multiply with that into 100. So say for example, it's approximately 33.33%. So in this patient, obviously, I'm going to categorize this patient under either stage 3 or stage 4. That is how you are going to calculate the bone loss. Okay, so another parameter in severity is tooth loss. So in tooth loss, in stage 1, it's going to be no tooth loss in stage 2 as well. In stage 3, less than 4 tooth is lost due to periodontitis. Here more than 5 tooth is lost or teeth is lost. Okay, so in severity 3 parameters are considered. Okay, one is clinical attachment level or loss, another one is radiographic bone loss, another one is tooth loss. Okay, so cal for stage 1, it's going to be 1 to 2 mm, stage 2 is 3 to 4 mm, stage 3 and stage 4 is more than 5 mm. Radiographic bone loss for stage 1 is less than 15%, stage 2 is 15 to 33%, stage 3 and stage 4 more than 33 or more than middle third. And then again tooth loss, 1 and 2 you are not going to have any kind of bone loss, 3 and 4, 3 less than 4 teeth is lost due to periodontitis, and 4 is more than 5 teeth or 5 tooth is lost due to periodontitis. This is severity, based on severity. Another one is based on complexity. In complexity, what they talk about is just the type of bone loss. Okay, so the type of bone loss, if you see in stage 1 and stage 2, it's going to be predominantly horizontal bone loss. Okay, in stage 3 and stage 4, it is going to be predominantly vertical bone loss. So one of the main feature distinguishing between stage 3 and stage 4 is these stage 4 patients will have increased mobility, bite collapse, severe ridge defects. Okay, these feature distinguish stage 3 and stage 4. So again, recapping, staging, there are 4 stages: stage 1, stage 2, stage 3 and stage 4, and each stage they are dividing into 2 based on severity, based on complexity. In the severity, I'm going to talk about 3 parameters: cal, radiographic bone loss, tooth loss. In the complexity, predominantly I'm going to talk about what type of bone loss it is. It is horizontal or vertical. Very simple, right? Now can you answer a question like a patient comes to you, okay? Patient is having clinical attachment loss of 1 to 2 mm. Okay, patient is having clinical attachment loss of 1 to 2 mm. But radiographically, when I see the patient is having vertical bone loss, cal is 1 to 2 mm, which points my diagnosis towards stage 1. But patient is having vertical bone loss, severe vertical bone loss, which represents stage 4. So what I'm going to do in this situation? Always remember, the worst parameter is considered. So in this patient, even though the cal is 1 to 2 mm, I'm going to take the worst parameter, that is severe vertical bone loss. So I'm going to categorize that patient as stage 3 or stage 4, depending upon other conditions, other parameters. Okay, so these patients can never be grouped under stage 1. So I'm going to take the worst parameter. I'm going to choose the worst parameter. Always choose the worst parameter to diagnose a disease. Even though some of the parameters matches your stage 1 and stage 2, the worst parameter, if the worst parameter matches your stage 3 or stage 4, it is going to be stage 3 or stage 4. Always remember that. Fine. Okay, now after staging, we are going to talk about grading. So in the grading, if you see, 3 gradings are there: grade A, grade B and grade C. Okay, so all these gradings, okay, they are classified based on the bone loss per age, bone loss to age, and then I'm going to talk about the patient smoking status, sugar levels, diabetes, and then I'm going to tell the disease progression based on this. Okay, so I'm going to categorize these patients grading based on the 4 parameters. So bone loss to age, it should be less than 0.25. If it is between 0.25 to 1 and more than 1%. I'll tell you how to calculate this also. So bone loss per age, if you see, it's very simple. Okay, see, we know how to calculate radiographic bone loss, right? Say for example, the patient is having 50% of radiographic bone loss. How to measure radiographic bone loss? Very simple. What I'm going to do is I'm going to measure the distance from the CJ to the crest of the alveolar bone, and then I'm going to divide that with the distance from the CJ to the root apex, and I'm going to multiply by that 100. Multiply that with 100. Okay, I'm going to get the certain percentage, that is a radiographic bone loss. Say for example, this patient has a radiographic bone loss of 50%, and he or she is 30 years old. So what I'm going to do is, I'm going to divide 50% by 30. Okay, that will give me approximately 1.66 around. So that will obviously come under grade C. Okay, so bone loss divided by their age. Very simple. So next, smoking status. So non-smoker, patient is not diabetic, and there is going to be less risk of disease progression. B, patient is having smoking habit less than 10 cigarettes per day and less than 7% of HbA1c, and they are moderate risk. These patients are moderate risk patients. And if the patient is smoking more than 10 cigarettes per day, more than 7% HbA1c, then they are at high risk of disease progression. Okay, so this is how grading is done. Okay, so now if a patient comes to you, you are going to tell me the diagnosis. Okay, if a patient comes to you, say for example, with a clinical attachment loss of 5 mm, okay, patient is having 5 tooth missing, patient is a smoker, smokes less than 10 cigarettes per day, and patient is having HbA1c of less than 7%. Okay, so I'm going to group these patients under stage 4 if the patient is having less than or more than 5%, 5 tooth loss, and more than cal of 5 mm. I'm going to classify these patients as stage 4 grade B. If the patient is having 4 tooth loss and patient is having cal of more than 5 mm, stage 3 grade B. Always take the worst parameter. Cal 1 to 2 mm, severe vertical bone loss, stage 4. Patient is having a bone loss per age less than 0.25, but patient is an heavy smoker, more than 19 cigarettes. According to this, more than 10 cigarettes per day. Then I'm going to call these patients as stage 4 grade C. Okay, always choose the worst parameter. Okay, now another one important feature is the location and distribution, extent and distribution. So if you look at the extent and distribution, they have classified it under as localized, generalized, or molar incisor pattern. Localized, generalized, or molar incisor pattern. So localized means less than 30% of sites affected. Generalized is more than 30% of sites is affected. Molar incisor pattern is molars and incisors are involved with less involvement of other tooth. Okay, so what do you mean by less than 30% of the sites is a tooth will have 6 sites: midbuccal, midlingual, mesiobuccal, mesiolingual, distobuccal, distolingual. These 6 sites I should probe. So a tooth will have 6 sites. Say for example, 32 tooth, 192 sites. So I'm going to, if a patient is having 32 tooth, I'm going to assume or I'm going to tell only if the patient is having pockets less than 55 sites. I'm going to call these patients as localized, because I'm going to divide 192 by 30. It will come approximately around 50 to 55. So if the probing depth or pocket is less than 55 sites for a patient with 32 tooth, I'm going to call that as localized. If the patient is having more than 55 or more than 60, then I'm going to call that patient as generalized. It depends upon the sites and not the tooth. A tooth will have 6 sites of probing depth. So I'm going to assume the patient is having 32 tooth, 32 into 6, 192. So to be considered as a localized in a stage, whatever stages, so the patient should have a pocket of only